Ibuprofen, the pill everyone trusts. Ibuprofen is so common, it barely registers as a drug anymore. Advil, Motrin, the thing you take after a headache, a workout, a hangover. It's been around since the 1960s, developed by a British chemist named Stuart Adams, who reportedly tested his first dose on himself before a work presentation. It passed. The presentation went fine, and the world got one of its most widely used drugs. But here's what most people don't know about ibuprofen. It doesn't actually target pain directly. It works by blocking enzymes called COX1 and COX2, which are responsible for producing prostaglandins, the chemical signals your body uses to create inflammation and sensitize nerve endings. No prostaglandins, no inflammation signal. No inflammation signal, no pain perception. Clean, simple, effective, except for one problem. Those same COX enzymes also protect your stomach lining. Block them long enough, and the stomach starts to eat itself. Chronic ibuprofen users have significantly elevated risks of gastric ulcers, internal bleeding, and kidney damage, not from overdose, but from regular use. The pill millions of people take casually, daily, without a second thought, is quietly doing damage most of them won't notice until it's serious. And ibuprofen is the safest rung on the ladder. Tylenol, the deceptive one. Acetaminophen, sold as Tylenol in North America, paracetamol almost everywhere else, kills more people by accidental overdose than almost any other over-the-counter drug on the market. Not because people are being reckless, because it looks harmless. Unlike ibuprofen, acetaminophen doesn't reduce inflammation. It works centrally, inside the brain and spinal cord, blocking pain signals before they fully register. It's gentler on the stomach. It doesn't thin your blood. It's safe for children. It's the go-to recommendation for pregnant women. On paper, it sounds like the better option. The problem is the liver. Acetaminophen is metabolized by the liver into a toxic byproduct called NAPQI. At normal doses, the liver neutralizes NAPQI almost instantly, but increase the dose even slightly, and NAPQI builds up faster than the liver can handle it. The result is acute liver failure. And the terrifying part, the symptoms don't show up for 24 to 72 hours. By the time someone feels sick, the damage is already catastrophic. The recommended daily limit is 4,000 milligrams. A single extra-strength Tylenol is 500 milligrams. That sounds like a wide margin, until you factor in that acetaminophen is a hidden ingredient in over 600 combination medications. NyQuil, Percocet, Vicodin. People double and triple dose without ever realizing it. This is the drug sitting in everyone's medicine cabinet, and it's responsible for roughly 56,000 emergency room visits per year in the United States alone. Tramadol, the drug in the middle. Tramadol occupies a strange, uncomfortable space on the ladder. It was introduced in the late 1970s and marketed for decades as a non-narcotic painkiller, a safer alternative to the heavy opioids doctors were increasingly reluctant to prescribe. For years, it wasn't even classified as a controlled substance in the US. That classification changed in 2014 because tramadol is not what it was sold as. It works through two mechanisms simultaneously. First, it weakly binds to opioid receptors, the same receptors that morphine and heroin target. Second, it inhibits the reuptake of serotonin and norepinephrine, essentially functioning as a mild antidepressant on top of a mild opioid. That dual action made it feel uniquely effective. It also made it uniquely unpredictable. Here's what the safe label missed. Tramadol is a prodrug. It doesn't become fully active until the liver converts it into a compound called O-desmethyltramadol, which is significantly more potent than tramadol. And the speed of that conversion varies wildly between individuals based on genetics. Some people metabolize it slowly and feel almost nothing. Others metabolize it rapidly and experience effects closer to a strong opioid hit. There were also the seizures. Tramadol lowers the seizure threshold, meaning people with no prior history of seizures were suddenly experiencing them after standard doses. And because it affects serotonin, combining it with antidepressants, which millions of its users were also taking, could trigger serotonin syndrome, a potentially fatal condition. The safe opioid wasn't safe. It was just misunderstood. Morphine, the original opioid. Before oxycodone, before fentanyl, before the entire modern opioid crisis, there was morphine. Isolated from opium in 1804 by a German pharmacist named Friedrich Zerturner, it was named after Morpheus, the Greek god of dreams. That name wasn't an accident. It was a drug that made suffering disappear so completely, it felt like sleep. Morphine works by binding directly and powerfully to mu-opioid receptors throughout the brain and spinal cord. It floods the system with artificial euphoria, shuts down pain signaling at the source, and slows everything down. Breathing, heart rate, anxiety. For soldiers wounded in the Civil War, it was the difference between dying in agony and surviving long enough to be treated. For terminal cancer patients today, it still is, but morphine revealed something medicine wasn't ready to accept. The body adapts. Within days of regular use, opioid receptors begin to downregulate. They become less sensitive, requiring more drug to produce the same effect. Tolerance builds, then dependence, then withdrawal. A physical process so severe it includes seizures, vomiting, uncontrollable muscle spasms, and a psychological desperation that overrides rational thought entirely. Morphine didn't just treat pain. It taught the body to need it. Every opioid that came after, codeine, oxycodone, hydromorphone, fentanyl, is a variation of the same fundamental mechanism morphine exposed in 1804. They just got progressively better at triggering it. That's the inheritance of the latter. Codeine, the gateway nobody talks about. Codeine is morphine's quieter cousin. It's in cough syrups. It's prescribed for mild to moderate pain after dental procedures. In some countries, you can buy it over the counter without a prescription. It has the reputation of being the weakest opioid, the one doctors reach for when they want to help without committing to anything serious. That reputation is exactly what makes it dangerous. Codeine is itself almost entirely inactive. The body has to convert it into morphine to produce any pain relief at all, a process handled by a liver enzyme called CYP2D6. In most people, this conversion is slow and controlled, but roughly 1 to 7% of the population are ultra-rapid metabolizers. Their bodies convert codeine into morphine so fast and so completely that a standard dose hits like a full opioid surge. There are documented cases of infants dying after breastfeeding from mothers prescribed routine post-surgical codeine because the mother's milk was saturated with morphine they never knew they were producing. And for everyone else, the standard metabolizers who feel just a mild relief, there's still the tolerance problem. Codeine activates the same receptors as every other opioid. The brain doesn't care that the dose was small. It notices the signal. It adapts. And for a percentage of people who start with a cough syrup prescription, that adaptation is the first step on a path they didn't know they were walking. The gateway drug conversation usually focuses on cannabis. It should be focusing on this. Oxycodone, where medicine becomes war. In 1996, Purdue Pharma released OxyContin, an extended-release formulation of oxycodone, and began one of the most aggressive pharmaceutical marketing campaigns in history. Doctors were told it was less addictive than other opioids because of its slow-release formula. Sales reps distributed branded merchandise. Physicians who prescribed it in high volumes were flown to pain management seminars at luxury resorts. Within a decade, opioid prescriptions in the United States tripled. Oxycodone works by binding to mu-opioid receptors in the brain, the same receptors that produce euphoria, pain relief, and sedation. At therapeutic doses, it's genuinely effective for severe pain. Post-surgical recovery, late-stage cancer, injuries that ibuprofen can't touch. The drug itself isn't the villain. The story of how it was deployed is. The extended-release formula that was supposed to prevent abuse, users discovered that crushing the pills and snorting or injecting the powder delivered the entire dose at once. Purdue eventually reformulated OxyContin to make it harder to crush, but by then, hundreds of thousands of people were already dependent. And when prescriptions dried up, many turned to heroin. It was cheaper, easier to find, and hit the same receptors. That transition from prescription oxycodone to street heroin is the direct line that created the modern opioid crisis. Over 500,000 Americans have died from opioid overdoses since 1999. Not from rare accidents, from a product that was sold as medicine. The top of the ladder. And then there's fentanyl, synthetic, 100 times more potent than morphine. Originally designed for end-of-life cancer pain, patients who had developed tolerance to every other opioid available. A drug so powerful, it's measured in micrograms. Illicitly manufactured fentanyl began flooding the drug supply around 2013. It was cheap to produce, easy to conceal, and could be pressed into pills that looked identical to legitimate oxycodone. A counterfeit pill with just 2 milligrams of fentanyl, an amount smaller than a few grains of salt, is a lethal dose for a non-tolerant person. By 2023, fentanyl had become the leading cause of death for Americans aged 18 to 45. Not car accidents, not gun violence. A synthetic opioid that fits in an envelope. Every painkiller on this ladder was developed to reduce suffering. Every single one started as a solution. The pattern isn't that these drugs are evil, it's that the line between medicine and poison is almost always a matter of dose, context, and who controls the information. The same molecule that helps a cancer patient sleep through the night is the molecule that ends someone else's life on a Tuesday afternoon. And most people who start at the bottom of the ladder never plan to climb it. That's what makes it a ladder.